Good afternoon, everyone. My name is Nancy Trick. On behalf of Teleflex and as manager of our clinical education department, I want to thank you for joining us for the second of a three-part series of webinars focusing on arterial catheterization. Following our presentation, we welcome your questions. Please enter your questions on the questions section of the GoToWebinar panel. This webinar is accredited for 1 contact hour for nurses and respiratory therapists. The title of today's webinar is Presenting Central Line Associated Bloodstream Infections Associated with Arterial Catheters. Speaking on this very important topic is Dr. William Jarvis. Dr. Jarvis is a world-renowned speaker and author on infectious diseases, epidemiology, and infection prevention. Currently, he is the president of Jason & Jarvis Associates, a global medical consulting firm specializing in infectious diseases and prevention and public health. While working within the CDC, Dr. Jarvis served as the acting director of the Hospital Infections Program and director of extramural research. Additionally, he developed the CDC's National Nosocomial Infections Surveillance System. Dr. Jarvis has published over 400 peer-reviewed publications, 50 book chapters, edited 3 books, and over 50 CDC surveillance reports. At the end of this webinar, you may obtain 1 contact hour by going to www.saxtesting.com/VH. Please complete the post-test and evaluation form. Upon successful completion and submission, you will be able to print out your certificate of completion. Our provider number through Sax Communications is approved by the California Board of Registered Nursing, provider number 14477. This program has been approved for 1 contact hour of CRCE by the AARC. No off-label use of products will be discussed, and Dr. Jarvis did not disclose any conflicts of interest in relation to this presentation. Please join me in welcoming Dr. Jarvis.
Thank you, Nancy. And thank you, everyone, for joining us for this webinar on prevention of central line associated bloodstream infections associated with arterial catheters. Our objective today is to first discuss the recent literature comparing infection rates with arterial and central venous catheters. Second, to describe the Centers for Disease Control and Prevention's 2011 guideline recommendations on arterial catheters with special emphasis on prevention of catheter-related infection. And third, to discuss the consequences of these recommendations and of implementing insertion and maintenance bundles or other prevention interventions in clinical practice. Before beginning, I think it's important to look at this hierarchy of medical evidence. When we're thinking of what interventions we should be placing as a high priority for implementation in our facilities, I believe that we should be looking at the extent of evidence to support that intervention and be very aggressive about implementing evidence-based recommendations. If we look at this pyramid of medical evidence, starting at the bottom we have in vitro or test tube research studies. Oftentimes, studies that are done in a test tube suggest that they may have some benefit in humans, but until you really test them in humans, you really don't know. Animal research is the same thing. Many different drugs or other interventions have looked wonderful in research in animals, but then when it's tried in humans, it fails. A good example of this is just recently in the New England Journal. There was a treatment for overwhelming sepsis that test tube studies looked like it would work. Animal studies, it did work, and then when it was tried, actually in a small human study, it worked, but in this larger randomized controlled trial, it was shown to have no benefit whatsoever. Then we have ideas, editorials, opinions. Oftentimes those have very few of any references. And then we have case reports. Clinicians often practice what I call anecdotal medicine. I did this once, it works, I'll do it the rest of my career. The problem with case reports in anecdotal medicine and even case series is you have no comparison group. So you have no idea whether it's really having an impact or not. And that's why if we draw a line right above case series, below that line is what we would call non-epidemiologic studies. And above that line is what we would call epidemiologic studies. The majority of these epidemiologic studies serve as a basis for recommendations in our guidelines. Case control studies, where you take a group of cases and randomly select a group of controls and compare outcomes. Or a cohort study, where you take an entire group and follow them prospectively, or sometimes retrospectively, to look at outcomes. And then we have randomized control trials, which are the penultimate in design of an epidemiologic study, which the advantage over, or a potential advantage over case control or cohort studies, is that randomized control trials hopefully can control for other confounding variables that might lead to the outcome. But oftentimes randomized control trials end up being underpowered, because when you add a study nurse or have a funded study, oftentimes the baseline rate of the outcome that you're trying to implement preventive measures for goes down in the control group just because you have all this other activity. So then we have a thing called meta-analyses, and meta-analyses are taking a group of randomized control trials, many or most or all of which may be underpowered, and adding them together to increase the power. We're somewhat fortunate in terms of the recommendations made for prevention of central line-associated bloodstream infections, in that we have more randomized control trials than probably any other guideline that CDC has put out. So we really should be looking at what kind of study do we have, what is the power of that study, and how strong is the epidemiologic design for our implementing it in our clinical setting. So if we move to arterial catheters, approximately 6 million arterial catheters are placed each year in the United States. They're assumed to be at low risk, primarily because of their relatively short duration of insertion. If we look back at the 2002 CDC IV guideline, it did not even advocate for surveillance of arterial catheter-related bloodstream infections. In fact, to quote from that guideline, they say they have low infection rates, are, quote, rarely associated with BSI. Many clinicians consider arterial catheters to pose little BSI risk. Yet, if we look at arterial catheters, they are among the most heavily manipulated catheters in the intensive care unit or operating room. And we know that the more the catheter is manipulated, the greater the risk for contamination and subsequent infection. We're going to look at a number of studies today that hopefully will convince you that just like with central venous catheters, we should be applying insertion and maintenance prevention bundles to arterial catheters as well. But first, to get perspective on the relative risk of bloodstream infection with central venous versus arterial catheters, and in fact all of these different catheters, Dr. Dennis Mackey published a study in Mayo Clinic's Proceedings in 2006 where he and his colleagues did an exhaustive review of the published literature and identified every study that was prospectively examining intravascular device, or IVD, bloodstream infection, or BSI. This included peripheral IV catheters, midline catheters, arterial catheters, pulmonary artery catheters, peripherally inserted central catheters, central venous catheters, hemodialysis catheters, Hickman catheters, central venous ports, and even left ventricular assist devices and intra-aortic balloon pumps. So this was an exhaustive search of the literature. If we look at the data, and I've highlighted 3 different groups here. You can look at this at your leisure later, and what you'll see is on the left-hand side of the device, starting with peripheral IVs, plastic, steel needle, needles cut down, then midlines, and going down all the way to left ventricular assist devices. The number of studies, the number of catheters, the number of intravascular devices, the number of BSIs, and on the far right, the rate of intravascular device-related bloodstream infection per 1,000 intravascular days. Highlighted in red, first one there, are arterial catheters for hemodynamic monitoring. We can see there's 14 catheters, or 14 studies, excuse me, over 4,000 catheters, and the pooled mean BSI rate is 1.7 per 1,000 intravascular days with a range of anywhere from 1.2 to 2.3. Now let's compare that to short-term non-cuff CVCs. If we do, we see for non-tunnel catheters, the BSI risk is 2.7 per 1,000 intravascular days, and tunneled is 1.7 per 1,000 intravascular days. If we then look down to pulmonary artery catheters, we see that the risk is even higher at 3.7 per 1,000 catheter days with a range of 2.4 to 5. So even here, looking at the combined published literature, we can see that the rate of infection, bloodstream infection, associated with arterial catheters is comparable to that seen with short-term non-cuff CVCs, and obviously many other catheters as shown on the slide. So now let's move to two studies. The first one is by Coe and colleagues, published in the Critical Care Medicine in 2008. This is a study comparing peripheral arterial catheters to central venous catheters. There had been few studies assessing the risk of colonization or infection and concurrently used arterial and central venous catheters. So these authors prospectively measured arterial catheter or AC colonization and bloodstream infection or BSI. They wanted to assess what were the risk factors for arterial catheter colonization and then compare arterial catheter colonization and bloodstream infection to concurrently use CVCs. So the patients had both the peripheral artery catheter and the central venous catheter in place at the same time. This was a prospective 2-year cohort study. All patients in the intensive care unit were followed. Testing was done to determine colonization or infection in both the peripheral arterial catheter as well as the concurrently cited CVC. This study was done in an 8-bed ICU and a 350-bed hospital in Australia. Two outcomes were measured: the incidence of catheter days of colonization, and colonization was defined as greater than 15 colonies, and the catheter-related bloodstream infection. As shown on this slide, there were about 320 arterial catheters inserted in about 250 patients. They had about 1,100 catheter days, and the average duration of these arterial catheters was 3.4 days. In contrast, there were about twice as many, 618 central venous catheters inserted in about 400 patients. They observed about 4,000 catheter days, and the average duration was about 6.5 days. If you look at the figure on the right, it shows the proportion of arterial catheter and central venous catheters that remain uncolonized on removal. So on the x-axis, we have the time to catheter removal, ranging anywhere from 0 up to 28 days. And on the y-axis, we have the proportion of catheters remaining uncolonized. So under the best of circumstances, we want that line at the top to start at 1 and stay at 1. That as it decreases, more and more of those catheters are becoming colonized. And what you see is, certainly up to about 10 days, the dotted line for CVCs, or hatched line, is virtually identical to the solid line for arterial catheters. And in fact, when you apply statistics to this figure, you find that there's not a statistically significant difference between the two. On this slide, they looked at arterial catheter colonization rate, central venous catheter colonization rate, and then catheter-related bloodstream infection, or CRBSI. As you can see under colonization, the rate for arterial catheters was 15.71. This is per 1,000 catheter days, compared to 16.83 for central venous catheters. This difference was not statistically significant. So the risk of colonization of all of the arterial catheters was identical to the risk of colonization of the central venous catheters. Next, they look at CRBSI. The rate for arterial catheters was 0.92, so almost 1, and for central venous catheters was 2.23. Again, this difference was not statistically significant. Interestingly, next the authors looked at the risk of catheter colonization by duration of catheterization. So on the far left you see the number of days. Catheters in place from 0 to 3, 3 to 6, 6 to 9, 9 to 12, or 12 to 15 days. And then over what percent of the catheters that were removed, all of which were tested, were found to be colonized. So at 0 to 3 days, those catheters that were removed, about 1.6% of them were colonized. By 3 to 6 days, it more than tripled to 6.3% of catheters colonized. By 6 to 9 days, it doubles yet again to 13%. 9 to 12 days doubles yet again to 25%. And 12 to 15 days doubles yet again to 50%. So catheters in place for 12 to 15 days, arterial catheters, half of them will be colonized. And we know that colonization is a prerequisite step to infection. Interesting, if we look at the mean arterial catheter duration in days on the far right, you see that each one of those, the mean day is actually toward the lower end of the spectrum. So for 0 to 3 days it was 1.4, from 3 to 6 days it's 4.1, and when we get to 12 to 15 days it's actually 12.9. So in fact, if the mean was at the upper limit of 3 days or 6 or 9 or 12 or 15 days, the percent colonized would be even higher. Obviously, this slide shows that the longer the arterial catheter is in place, the greater the risk for colonization. Next, Cohen and colleagues looked at 2 additional factors. Where in the hospital the catheter was placed, and then where in the patient was the catheter inserted. On the left-hand side figure, you can see the time to catheter removal, again on the x-axis, and the proportion remaining uncolonized on the y-axis. If you look at the solid line, that's intensive care unit, and again, as I told you, you'd like that line to remain up at 1. That means no catheters colonized. And you can see for intensive care unit, it's a very slow decline. In contrast, if you look at both emergency room and operating theater, they become colonized much more rapidly. For those of you in infection control, this is probably not a surprise. The infection control practices in terms of prevention interventions with catheters tend to be better in intensive care units, a little bit less good in operating theaters because many of our anesthesiologists don't apply some of our infection control recommendations, and even worse in the emergency department. 1, because of lack of knowledge perhaps, but 2, because of the circumstances they're dealing with, many of these catheters having to be inserted urgently where perhaps the best techniques aren't used. But it certainly shows in this hospital, may be true in many others, that if these catheters are placed in the intensive care unit where presumably infection control measures are better, that the risk of colonization is much less. On figure 3 on the right-hand side, we see that it makes a difference where you insert that catheter. If the catheter is inserted in the cubital, you can see at the very top dotted line, it basically stays at 1, very low risk of colonization. With radial, the risk increases a little bit more, but neither of them are comparable to femoral, which become colonized much more rapidly. So in conclusion, Coe et al. Found that their study documented that arterial catheters were at equal risk to central venous catheters for colonization and for bloodstream infection. That the risk of colonization was partially dependent upon three factors: where in the hospital the catheter was inserted, which is probably a proxy for the intensity of infection control measures during insertion. Second is the site of insertion, which is probably a proxy for bioburden. We know the bioburden is much greater in the femoral area, second highest in the jugular, third in the subclavian, fourth in the brachial for central venous catheters, and the same would be true for arterial catheters. And then last, duration of catheterization. These authors then argued to reduce the risk of arterial catheter colonization and infection, more aggressive infection prevention measures are indicated. Now let's move to a study by Lucette and colleagues, published in Critical Care Medicine in 2010. This is from a randomized controlled trial in 7 hospitals, medical, surgical, and surgical ICUs in Paris, France. And the objective of this study was to compare the daily risk and risk factors for colonization and catheter-related infection between arterial catheters and central venous catheters. So certainly one of the distinctions here between the Coe study was peripheral arterial catheters. The majority of the catheters in this study are central arterial catheters. Data were used from a randomized controlled trial that they previously did comparing the use of the biopatch or chlorhexidine impregnated sponge dressing to transparent dressing. They also looked at changing the dressing at 3 days versus 7 days. In this study, they looked at the daily hazard rate and then identified risk factors for colonization using a marginal Cox model for clustered data. They had about 2,100 patients with at least one intravascular catheter. About 1,600 of these patients were enrolled. Of those, about 1,525 had at least one accessible catheter. About 1,200 had an arterial catheter, at least one. 1,400 had at least one central venous catheter, and almost 1,100 patients had both an arterial and a venous catheter. They had a total of 3,532 catheters, almost equally split, 1,617 arterial, 1,915 central venous, giving them 27,541 catheter days, where these catheters were routinely cultured and then the data were analyzed. So this is a fairly robust study. Lucette and colleagues found that colonization rates did not differ between arterial catheters and central venous catheters. 7.9% of arterial catheters were colonized versus 9.6%. When looked at as per 1,000 catheter days, it was 11.4 for arterial versus 11.1 for central venous catheters. The differences were not statistically significant. Next, they looked at catheter-related infection rates. Arterial catheters, the rate was about 0.68%. Central venous catheters, 0.94%. When looked at as a rate, it was 1 per 1,000 catheter days with arterial catheters and 1.09 per 1,000 catheter days for central venous catheters. Again, statistically not significant difference between the two, and also very similar to what Coe and colleagues found for peripheral arterial catheters. On this slide, they were looking at the daily hazard rate for catheter colonization. So on the x-axis is the days after catheter insertion, and the y-axis is the catheter becoming colonized. The dotted line is central venous catheters, and you can see that there's a stepwise increase in risk of the catheter becoming colonized until about the 5th or 6th day. And then for central venous catheters, it plateaus. In contrast with arterial catheters, the daily risk just keeps rising. From the day you insert it until the day that you pull it, that risk increases each day that it will become colonized. And similar to the CO study, where they found that by 12 to 15 days, 50% of the catheters were colonized. If we look at the microorganisms causing either colonization or infection, certainly in terms of colonization, there's no surprises. The largest percentage is about 50% for coagulase-negative Staphylococci, and then Staph aureus, other gram-positives, and then about 30 to 40% in terms of total being gram-negative organisms. At the bottom third of the slide, if we look at the organisms causing bloodstream infections, there's some interesting differences between venous and arterial catheters. Number one, Staph aureus is obviously important, accounting for about 9% of arterial catheter infections, but accounting for about over 20% for central venous catheters. One kind of striking difference here is that for Pseudomonas and Enterobacter, the proportion of infections with arterial catheters is much higher than with central venous catheters, but certainly a wide spectrum of bacteria and fungi that we commonly see causing bloodstream infections. So Lucette and colleagues concluded that the risk of colonization and catheter-related infection did not differ between arterial catheters and central venous catheters, indicating that arterial catheter use should receive the same precautions as CVC use. So again, similar to what Coe and colleagues were recommending. They then pointed out that the daily risk was constant over time for CVCs after the 5th day, but increased significantly over time after the 7th day for arterial catheters. They then suggested that it might be worthwhile to do a randomized controlled trial of scheduled arterial catheter placement. Interestingly, that study has already been done about 20 years ago by Barry Farr at University of Virginia, where he did a study of routine replacement of arterial catheters and found that in fact it did not decrease infections, but did increase mechanical complications. So it's conceivable that we use arterial catheters slightly different today than we did at the time of that study. Perhaps it's worth re-examining again, but at least the data that we have so far, both for arterial and for venous catheters, suggests that routine scheduled replacement is not effective, and actually it's certainly one of the recommendations from CDC not to do. If we look at all of the published literature comparing arterial and venous catheters, we've talked about the Coe and the Lucette study. Traore and colleagues did a study looking at colonization and found 9.4% for arterial versus 12% for central venous catheters. In terms of colonization rate per 1,000 catheter days, this was not statistically significantly different. Then we have 2 additional studies that look specifically at BSI rate, again per 1,000 catheter days. Dr. Mackey at University of Wisconsin found a rate of 1.4 for arterial catheters versus 2.9 for central venous catheters, again not statistically significant. And Estravi and colleagues from Europe found a BSI rate of 3.7% for arterial catheters and 4.6% for venous catheters, again not statistically significant. So all 5 studies that we have looking at either colonization and or bloodstream infections find that the risk of colonization of arterial and venous catheters is the same, and the risk for bloodstream infections is the same. So if we then go back to the 6 million arterial catheters that are inserted annually in the United States, and if we take the data from these studies, that the risk for catheter-related BSI or CRBSI ranges from 0.7 to 3.7%, then there are approximately 42,000 to 220,000 arterial catheter-related BSIs annually. The grand majority, if not all of these, are missed because when a patient has signs and symptoms of sepsis, a culture is done of either the lumens of the venous catheter and or peripheral sticks, and no culture is done of the arterial catheters at all. Despite this burden of disease that we're missing, the majority of guidelines, including the Shea Compendium, the United Kingdom guidelines and even the CDC 2002 guideline did not recommend that prevention bundles be applied to arterial catheters. We're going to move now to the HCPAC 2011 IV guideline because it starts to push the prevention bundles that we use with central venous catheters toward arterial catheters. Let's look at some of the specific recommendations that have been made for arterial catheters. This is a 1A recommendations. These are strongly recommended for implementation and strongly supported by well-designed experimental, clinical, or epidemiologic studies. They relate to pressure transducers. First is to keep all components of the pressure monitoring system, that includes the calibration devices and the flush solution, sterile. Second, when the pressure monitoring system is accessed through a diaphragm rather than a stopcock, scrub the diaphragm with an appropriate antiseptic before accessing the system. I would argue that if you have a diaphragm or a stopcock, it should be viewed as being like a needless connector, and you should be scrubbing it with an appropriate antiseptic, which would be chlorhexidine with alcohol or 70% alcohol. Third, do not administer dextrose-containing solutions or parenteral nutrition fluids through the pressure monitoring circuit, because we know that those fluids high in glucose, and as a result, they're wonderful for bacteria and promote growth. And then 4, sterilize reusable transducers according to the manufacturer's instructions if the use of a disposable transducer is not feasible. Next, we move to 1B recommendations. These are strongly recommended for implementation and supported by some experimental, clinical, or epidemiologic studies and a strong theoretical rationale. So for umbilical catheters, it's to clean the umbilical insertion site with an antiseptic before catheter insertion, specifically to avoid tincture of iodine because of the potential effect on the neonatal thyroid. Other iodine-containing products, such as povidone iodine, can be used. And then add low doses of heparin to the fluid infused through the umbilical artery catheters. Other 1B recommendations on transducers, administration sets, and infusions. To use disposable rather than reusable transducer assemblies whenever possible. To replace the disposable or reusable transducers at 96-hour intervals. And replace the other components of the system, including the tubing, continuous flush device, and flush solution at the time the transducer is replaced. And then third, replace the tubing used to administer blood products, or fat emulsions, especially those combined with amino acids and glucose in a 3-to-1 mixture or infused separately, within 24 hours of initiating the infusion, because we know with blood products, fat emulsion, glucose-containing solutions, that if they get contaminated, that you have approximately 4, maybe 5 hours where the organisms don't grow, and then they start growing rapidly. So within 24 hours, reach very high numbers. Other 1B recommendations that are specific to peripheral artery catheters. In adults, use the brachial, radial, or dorsalis pedis sites, and these are preferred over the femoral or axillary sites of insertion to reduce the risk of infection. And that's because the bioburden at the femoral and the axillary sites are much higher than radial, brachial, or dorsalis pedis. Keep in mind that in the femoral area you have about 10 to the 6 to 10 to the 8 organisms, whereas in the subclavian you're talking about 10 to the 2 to 10 to the 4, and brachial even less than that. And if you're doing skin antisepsis with either chlorhexidine with alcohol, or povidone iodine with alcohol, or alcohol, that even under the best of circumstances the skin will not be sterile. At least 20% of the organisms remain attached to hair follicles and sebaceous glands. And those are the organisms that are remaining there, hoping to attach to that catheter when you insert it. So obviously if you go into high bioburden sites, such as the femoral or axillary sites, your bioburden after skin antisepsis is much higher, and your risk for contamination of the catheter is much higher as well. And then number 2, a minimum of a mass, cap, sterile gloves, and a small sterile fenestrated drape should be used during peripheral artery catheter insertion. So it's use of what I call modified maximum barrier precautions. Everything's the same except the drape. Instead of using a large head-to-foot full body drape, you can use a small sterile fenestrated drape. Now we move to Category 2 recommendation. Now keep in mind that all Category 1, whether they be 1A, 1B, or 1C recommendations in the CDC guidelines, as stated by CDC, should be fully implemented. Now we're to Category 2. If we look at what are the criteria for that categorization, it's suggested for implementation and supported by suggestive clinical or epidemiological studies or a theoretical rationale. So the level of data to support these are less than the 1Bs or the 1As. In children, the brachial site should not be used. The radial, dorsalis, pedis, or posterior tibial sites are preferred, again, over the femoral or axillary sites of insertion for the exact same reasons we try to avoid femoral or axillary in adults. During axillary or femoral catheter insertion, full maximum barrier precautions should be used. It's cap, gown, mask, gloves, and a full head-to-toe body drape. Then replace arterial catheters only when there's a clinical indication. Remove the arterial catheter as soon as it's no longer needed, and do not routinely replace arterial catheters to prevent catheter-related infections. And then last, minimize the number of manipulations of and entries into the pressure monitoring system, because we know each time it's entered, each time it's manipulated, it increases the likelihood for contamination to occur. Use a closed flush system, that is a continuous flush, rather than an open system, one that requires a syringe and stopcock, because we know when a syringe and stopcock are used, that stopcock usually gets caked with blood. So biofilm can develop, there's proteinaceous material there for organisms if it becomes contaminated, and often the stopcock is not disinfected at all. And all of this is done to maintain the patency of the pressure monitoring catheters. Next, let's look at the Shea Compendium published by Marshall and colleagues in Itchy in 2008. They made some basic and special approaches for the prevention of central line-associated bloodstream infections and divided them into two groups: basic practices and special approaches. The basic practices, they said, should be implemented for all catheter insertions. This includes a catheter checklist listing all of the things that should be done each and every time a catheter is inserted. Hand hygiene by the inserter and those assisting before insertion of the catheter. Avoiding the femoral site, so avoiding the high-risk infection sites. Using a cart or kit that has everything in it that the inserter needs so they're not running around trying to find it. Using maximum barrier precautions, and using chlorhexidine with alcohol for skin prep. The Shea Compendium called this basic practices. I call it a catheter insertion bundle. An insertion bundle is trying to prevent infections associated with that catheter insertion. As we talked about, you have bacteria on the skin, at least 20% remain after skin antisepsis. So as you insert that catheter, you have an increased risk of picking up one or more of those organisms that can attach to the outside of the catheter, produce an exopolysaccharide or biofilm, reproduce, proliferate, cause colonization, and subsequently cause infection. Every study done has shown that this is the major pathogenic mechanism for infection early after catheter insertion, usually within 5 to 7 days. So it's logical that we have a group of basic practices aimed at trying to reduce the risk of infections associated with insertion. And if your patients only have a catheter in place for 1 or 2 days, that may be all you need. But the majority of our patients have catheters in for much longer than that. And that's when I think you need what I call a catheter maintenance bundle. The Shea Compendium says do basic practices, and if your catheter-related infection rate does not reach your institutional goal, which should be 0, you then move to applying special approaches. These special approaches include chlorhexidine bathing of ICU patients. If you look at the data, there are 2 studies in surgical ICU patients, and it hasn't really worked. In medical ICUs, it has worked much better. The majority of those, the predominant pathogen has been vancomycin-resistant enterococci, and chlorhexidine bathing works very well to reduce the bioburden of vancomycin-resistant enterococci, reduces contamination around the patient, reduces body burden of VRE, reduces healthcare worker colonization or contamination with VRE, and decreases BSI rate. Use of antiseptic or antimicrobial impregnated catheters, use of the chlorhexidine impregnated sponge disc or biopatch, which is placed at the site of catheter insertion, and after you've used the chlorhexidine with alcohol for skin prep, remember that within 12 to 24 hours after you've applied that, the organisms have grown back to the level that they were at before you applied that antiseptic. So having the biopatch or this chlorhexidine impregnated sponge disc releasing chlorhexidine at that site keeps that bioburden low and reduces the risk for both early and later infections. And then antimicrobial locks. And I guess the other thing I would add here is scrubbing of the hub, which would include the stopcock as well. So I think this catheter insertion bundle and maintenance bundle have been shown, recent studies have shown that actually the maintenance bundle has become more important than the insertion bundle, primarily because more and more people are already implementing the insertion bundle and fewer are implementing the maintenance bundle. If you have patients that have catheters in for prolonged periods of time, certainly more than 3 days, then the maintenance bundle becomes as or more important than the insertion bundle. If we were to come up with a potential arterial catheter insertion and maintenance bundle, obviously for insertion having a catheter kit, using maximum barrier precautions, and for peripheral artery catheters you could use a small fenestrated drape rather than the full body drape, use of chlorhexidine with alcohol for skin prep, having a justification for initial insertion, and making sure that the inserter is adequately trained and competent would all be logical ways to reduce the risk of contamination of that arterial catheter at the time of insertion. With maintenance, making sure the manipulator has training and is competent, catheter hub disinfection, whether that be the stopcock, the diaphragm, or a hub, using either alcohol or chlorhexidine with alcohol, use of the chlorhexidine impregnated sponge disc around the insertion site to keep that bioburden low and prevent organisms from either getting into the tract, causing either early or late infections, ensuring that during dressing changes you have appropriate aseptic technique being applied, having an appropriate nurse to patient ratios, removing that catheter when it's no longer necessary, and then advancing our surveillance and infection reporting to consider arterial catheters as a potential site of infection rather than just the venous catheters. In fact, what I find talking to both nursing personnel and infection control personnel is that there's a huge variation in how individuals are even assessing the patient that presents with signs and symptoms of sepsis. Some are obtaining one culture from one lumen from a central venous catheter and one peripheral stick. Some are doing no peripheral stick and 1 or 2 cultures out of the catheter. Others are doing only 2 peripheral sticks and no central catheter cultures. And virtually no one is doing any arterial catheter culture at all. Well, obviously, if different hospitals are using different methodologies for detecting bloodstream infections associated with central lines, whether it be arterial or venous, then everybody reporting them either to their own state or NHSN is like having a group of people speaking different languages. It's very, very difficult, if not impossible, to compare the results. So in conclusion, both arterial and catheter-related bloodstream infections are a major cause of patient morbidity and mortality. Prevention of catheter-related bloodstream infections requires a multifactorial approach. You cannot pick just one of the insertion bundle and one of the maintenance bundle elements. You need them all. Implementation of the CDC Central Line BSI Prevention Guideline recommendations from 2011 and the SHE 2008 Compendium recommendations is a good starting point, but we should keep in mind implementing new prevention evidence. If you think about it, the CDC guideline was published in 2002 and 2011. That's 9 years. If you were admitted to hospital in 2005, 6, 7, 8, 9, or 10, would you have wanted to wait for evidence that had been published in 2002 or 3? No. So we should be looking at new prevention evidence and applying it using our hierarchy of medical evidence that I showed you. If it's above the line of epidemiologic studies, then it should be seriously considered for implementation. And the more studies that show the same thing, the stronger it is. Then we should implement insertion and maintenance bundles. We need both insertion bundle for preventing those infections associated with catheter insertion and the maintenance bundle that tries to prevent the infections associated with manipulation of that catheter after insertion. The insertion bundle does not impact the maintenance bundle, and the maintenance bundle in general doesn't affect the insertion bundle. Then we need educating of our staff, ensuring adequately and properly trained staff. But it goes further than just education. We need to ensure that policy equals practice, and that gets to clinician accountability. We should be holding our clinicians accountable for implementing these insertion and maintenance bundles, and having both our hospital administrator mandate it and our physician and nursing directors of units and wards being held responsible for ensuring that it's done. And we should be monitoring catheter insertion and maintenance processes through the use of checklists, because we know the value of checklists are many. One, the checklist shows the clinicians what is essential that they do. Second, it provides you a mechanism for monitoring compliance with that checklist. And then third, if an infection occurs, you can pull that checklist out, and it provides you a much better root cause analysis as required by the Joint Commission than actually interviewing the clinician who inserted that catheter days or weeks or months ago and will tell you what they think they should have done because they can't remember what they did. And then last, catheter-related bloodstream infection rates as an outcome. We know that a comprehensive catheter-related BSI prevention program applied to both arterial and venous catheters can dramatically reduce infection rates and improve patient safety. Thank you very much.
Thank you very much, Dr. Jarvis. We have a long list of questions for you from our audience. However, before we get into those, I just want to remind our listening audience that you may obtain one contact hour for this webinar by going to www.sextesting.com/VH. Complete the post-test and evaluation form. Your certificate of completion will be issued immediately with a provider number approved by the California Board of Registered Nursing, number 14477, and this program has been approved for one contact hour of CRCE by the AARC. So our first question, Dr. Jarvis, is related to over-the-wire exchanges for finding a new, performing an over-the-wire exchange, or to simply find a new site for an arterial catheter insertion. And the listener is asking if there's evidence to prove a wire change doesn't reduce the infection rate.
I don't think there's any data to show that a wire exchange reduces infection rate, but certainly if you look at the CDC guideline, they make 3 recommendations regarding use of guidelines, specifically addressing central venous catheters, but could be other catheters as well. And those are that if you know you have an infection of that catheter, you should not do a guide wire exchange. Second, if that catheter is suspected, you haven't documented, but you suspect that it's infected, you should not do a guide wire exchange. That the only time you should do a guide wire exchange is when you're exchanging a catheter that you know does not have any sign of infection, any suspicion of infection, and you're exchanging it for mechanical complication reasons.
Okay, you mentioned mechanical complications, and another question is related to thrombosis and the occurrence and risk of thrombosis related to arterial catheters. And what are your thoughts in this area?
Well, there's not any good study that's certainly compared central venous to arterial catheters. I think from a theoretical point of view, one would think that central venous catheters would be perhaps at greater risk of partial or total occlusion than arterial catheters, because arterial catheters tend to have higher pressure of blood as well as movement of blood through them, whereas the venous catheters, oftentimes you'll have 1 or 2 lumens that aren't being used at all, and as a result having some occlusion in those is increased. Also, if you're infusing fluid that has heparin in it, which is more likely with an arterial than a venous catheter, that will reduce occlusion. But certainly occlusion, either partial or total, is an issue with any type of catheter that you have in place, but there's no data that I'm aware of yet that has compared the risk of occlusion with arterial versus venous catheters. I guess the only other point that I would make, and it's a little bit as an aside, we know that hemodialysis patients have one of the highest rates of infection of all of our patients, and certainly total and partial occlusions are a major issue with patients that have a central venous catheter in place for hemodialysis. And I would point out at least 2 recommendations in the CDC guideline. The first is I believe it's either a 1A or 1B recommendation for using of AV fistulae or grafts rather than catheters in hemodialysis patients. And the second is, I think it's a 1B recommendation, was not to use thrombolytic agents in the general patient population. And literally 2 months after the CDC guideline came out, there was a randomized controlled trial in the New England Journal of Medicine looking at use of thrombolytic agents in hemodialysis patients and looking at the risk for partial or total occlusion, and they found that there was a significant reduction when thrombolytic agents were used. So I think there may be an area where, specific to hemodialysis patients, we should examine the use of thrombolytic agents, realizing that many people believe that partial or total occlusions are a pathway or a step in the pathogenic mechanism to bloodstream infection. And if these hemodialysis patients had been monitored for a longer period of time, they may have found that those that had partial or total occlusions would be at higher risk for infections with those catheters as well. So that's a specific issue to hemodialysis.
Mm-hmm. Okay, we have a question for from a respiratory therapist who is inserting peripheral arterial catheters, and they are asking if, in your opinion, a head cap is mandatory in addition to all the other maximum barrier precautions they're taking.
Interesting question. I don't know of any study that's looked at that, and certainly as a part of maximal barrier precautions, that's not a specific recommendation.
Okay. Another question has to do with the use of CHD/alcohol scrubs on items other than the skin, and whether or not this is off-label use.
Definitely. CHG with alcohol or CHG alone, both have been recommended specifically by the FDA as an indication for skin antisepsis, and the recommendation that CDC makes, SHEA makes, INS make, etc., for use of chlorhexidine or chlorhexidine with alcohol for disinfection of either needleless connectors or other devices in off-label use.
Right, right.
On the other hand, I would point out that there are 2 studies that support that use. Now, obviously, the companies that make chlorhexidine haven't gone to the FDA with data and shown the FDA data that would allow them to have the indication to use it as a disinfectant as well as an antiseptic. Antiseptic is applied to the skin, which is what the indication is for chlorhexidine or chlorhexidine with alcohol, and a disinfectant is applying it to a non-animate object. There are 2 studies, one by Minahi and Mackey, where they took a variety of needleless connectors, immersed them in efficacus at about 10 to the 8th colony forming units per ml, let them dry, and then they took a syringe and either did no disinfection, shot it through, not surprisingly 100% were positive with up to 28,000 colony forming units. Second, they did a 3 to 5 second of what they describe as a wipe, forget the exact words, but basically a very good effective wipe of the connector with 70% alcohol for 3 to 5 seconds. When they attached the syringe and shot it through afterwards, 67% of those were still positive with up to 25,000 colony forming units. So imagine the effectiveness of your healthcare workers that do a 1-second disinfect. And then the third was use of a chlorhexidine cap that did not even exist commercially at the time. Only one was positive with 350 colonies. Subsequently, Kaler and Chen from San Diego did a study published in JAMA in January 2007 where they took a wider variety of catheters, a lower inoculum of 10 to the 5 rather than 10 to the 8, so the final colony forming units are probably 10 to the 2, 10 to the 3, took a wider variety of organisms, coagulated negative staph, Staphylococcus aureus, Klebsiella, and Candida, and then they did either a 70% alcohol, what they called scrub of the hub for 15 to 30 seconds, or use chlorhexidine with alcohol, again, for 15 to 30 seconds, and both of them were totally effective. So I think we at least have in vitro studies that show that chlorhexidine with alcohol would be an effective disinfectant.
Very good. A question comes regarding recommended nurse-to-patient ratios in ICU versus step-down units where patient assistance may be present, and do you see any difference in reported infection rates between those two environments with different types of care providers?
Excellent question. First of all, one of the CDC recommendations actually for central venous catheters that would apply to arterial as well is to have an appropriate nurse-to-patient ratio in the ICU and to be aware of if pooled nurses are being used. We have no good prospective data collected from a variety of institutions. We have about 4 studies, I believe, or 5, that have looked at the nurse-to-patient ratio and have found that as the number of patients per nurse goes up, the infection risk, particularly CLABSI rate, goes up. Also, at least one study out of Grady Hospital in Atlanta by Robert and colleagues showed that when pooled nurses came into the ICU, so they're nurses that are coming from other areas of the hospital that are not familiar with the prevention and intervention recommendations that are being applied, that the infection rate went up. So there's no doubt about it, the nurse-to-patient ratio and I would say the knowledge of the nurses that are in the unit both have an impact on BSI rates.
Very good. And one final question has to do with blood cultures, and in the situation where catheter-related infection is suspected, the listener is asking if the catheter tip should be cultured, if there should be a peripheral culture drawn, both, or just one.
Yeah, again, another excellent question, and there's a huge amount of confusion out there on this. If you look at the CDC for NHSN, their recommendation is to do 2 peripheral cultures only. If you look at the Infectious Disease Society of America, IDSA, or the American Society of Microbiology, ASM, recommendations, their recommendation is to do at least 1 lumen of the catheter and a concomitant peripheral stick. There's a study by Buza from Spain in ICU where he had patients that have triple lumen catheters in, and he cultured all 3 lumens independently and found that if he only had cultured 1 or 2 rather than all 3, that he would potentially miss, I don't remember the exact numbers, but somewhere in the 15 to 30% positive culture rate. Kind of a suggestion, if you're going to culture all lumens of a triple lumen catheter, which would make sense, you obviously first thing in your mind is cost. That's 3 cultures. Well, one way, you don't really care which lumen is positive, so why not take 2 to 3 cc's or 4 cc's out of each lumen and put it in one blood culture bottle. Saves you money, and you've actually determined if any of the lumens are positive.
That is an excellent suggestion.
Maybe I should just say my personal opinion is that the workup of a patient with potential sepsis should include cultures of all the lumens and a peripheral stick. You also should look at time to positivity. You should also consider, if it's positive, what are the data suggesting that's catheter contamination versus real infection? And then if it's real infection, should that catheter be pulled? And depending upon the organism, you may be able to treat through it or not. And the Infectious Disease Society of America guideline is particularly good at talking about how to do blood cultures, when you should do blood cultures, what you should do blood cultures of, and which pathogens you might be able to treat from. And the last point I would make is remember that semi-quantitative cultures of catheters, first done by Dr. Dennis Mackey, University of Wisconsin, is used to confirm a positive blood culture, to differentiate catheter colonization from true infection, not alone as a way to diagnose bloodstream infection. The the blood culture should be first.
Very good. Well, I believe we'll move forward with concluding our seminar for today. And we certainly appreciate your questions from our listening audience. Thank you very much for your attention. Please recall that this session has been recorded and will be archived at www.vesselhealth.org within 7 to 10 business days. We look forward to your continued support and attendance at our webinars, and we sincerely thank you, Dr. Jarvis, for your expertise in this area, which will certainly serve our patients very well. Good afternoon.